is keep the bone, keep the ligaments. So, test everything and keep what's good. And the bad part is the worn out surfaces, so we put on new surfaces. Now that can be done as a partial replacement if only a portion of the knee has worn. Or what we call total replacement isn't because everything's being replaced, it's because all the surfaces that come into contact with each other are getting renewed. The outpatient knee replacement, which really is a resurfacing procedure, is essentially the same as other knee replacements that I do for patients not as an outpatient. What's changed really that allows it to be done as an outpatient is the technique of getting it in. So using minimally invasive, muscle sparing, no tourniquet, avoiding the vessels so that there's very little bleeding associated. Long-acting medications, specific kinds of blocks and anesthesia. This whole combination of things and medications and technique is what allows that same surgery to be done in a way that allows people to go home and walk on it right away. But the expectation is still that it will last every bit as long as any other knee replacement that we do. Outpatient knee replacement is really for a select group of people. Typically it's going to be for people who are in their mid to late 50s, early 60s, still fairly active, people who are health oriented is the best, somebody who's keeping themselves in pretty good shape, physically fit, but where the pain of the knee being worn out has gotten to the point that it's no longer allowing them to do those kinds of things. That's really the ideal candidate for outpatient. I can evaluate the knee and tell you if it seems to me that it's getting worn out to the point that we need to do something. The somethings that we usually try are things that Tammy mentioned, and not everybody is happy to have them, but we'll often try arthritis medicine for a while. We'll try cortisone injections. There's other things that we can inject in the knee too. When people finally come to replacement, often they'll look back on those things and say, oh, well, that was kind of a waste of time because I ended up having to have a knee replacement. But for some people, it does help to push that off or even keep them from having it. So we will often try that, but it always takes place as a dialogue between the patient and the surgeon, really. Ultimately, when things aren't getting you to the level of function and comfort that you want, to live the life that you want to live, that's when we often will see patients come in and say, as Tammy did, we're going to stop fooling around with this. I need to be able to do things that I'm not being able to, or that if I try, cause me too much pain, so I just want to go ahead and have the replacement. I mean, it's the definitive thing. Injections will last for a while, months. Even if you get years out of injections or medicines, that's good, but replacements, last for decades. So it's kind of a personality thing, and it's ultimately not my decision. It's ultimately you, the patient's decision. I can tell you what the options are, and patients tell me it's time, or okay, let's try some of these other things first. Doing both at the same time is kind of a mixed bag. So when you do both at the same time, the problem from my perspective is twofold. The most important of which is that the risk of complication more than doubles. So it's not just twice as bad, it's more than twice the risk of having bad things happen. Now, bad things are rare, fortunately, with knee replacement. But the risk of infection or blood clots or heart attacks or strokes is real. It's not zero, and it more than doubles if you do both at the same time. A couple of good studies have shown that. The studies that show any difference show that it's riskier. So I always tell all my patients that. Despite that, some people still say, well, I just want to do both of them at the same time, I'll take my chances. If you're in good health, if your heart's good, your lungs are good, you can do it. Now, you can't do it as an outpatient yet. We've not even attempted it. But when you go to get up, you've got a problem because you don't have a good leg to stand on at first, right? So it's tougher to have both done and to get up and go. And it takes longer. And when I do both knees in a patient, their recovery is often about 10 weeks to 12 weeks long, just because it just slows you down. You get tired. Typically the surgery is about an hour, hour and a half. Something like that. The navigation adds a little bit of additional time, the data collection and then the computing time and stuff, but still most people are in and out of my time in the operating room is about an hour and a half. And there's production time on both ends, and then people, as I said, will stay for a couple of hours afterwards. People can come to our center, have a knee replacement, and basically stay at the center for about 4 hours, and then go home walking on it. Usually walking with a walker for 3 or 4 days, and that's it. Then maybe walking slow, and reaching out to touch something as they go for the first week or two. Therapy typically goes on for about 5 or 6 weeks and we're done. Most of the time, by the time we get somewhere in the 3rd or 4th week, people are doing better than they were before the surgery, both functionally and comfort-wise.
They can really feel the difference.
Driving at that point, yeah. So it's typically about half the length of recovery. The materials are really, really good. I haven't seen anybody wear one out yet, and I've been putting them in for 20 years now, right? So what has changed mostly is that the materials have gotten even better over time. But the way that I'm doing the surgery now is more technique that allows us to do it, and certain medications and things like that. It's a combination of things that allows us to do them as outpatients. I'll tell you, what I tell my patients is that I've been putting knees in now, and I've done thousands, literally thousands of knee replacements over the course of 20 years, and nobody has worn one out yet.